Everybody. I am going to give a overview of hypertension because to understand any pharmacologic action of a medication, we first need to know, guess what? The physiology, which is the best. So I'm going to go over some background and etiologies, which means causes of hypertension. Um, and then once you know the receptor subtypes and where those receptors are located, all the drugs are going to make sense. Again, there's nothing that you really have to memorize if you understand the physiology. So we'll go through the different receptor subtypes, where they're located. I'm going to talk to you about one of my favorite systems, the renin-angiotensin-aldosterone system, the RAS. And that is supposed to be a life-saving mechanism in the case that you go into shock and your heart starts to fail and it's going to raise your blood pressure. However, that is something that is hyperactive in some individuals, and you're going to see some differences with country of origin and gender as well. Finally, I will give a second talk where I talk specifically about the medications, but for now, let's get into the physiology. So, when we're talking about hypertension, boom, high blood pressure. That was a little intense. So, I'm going to make it go back. The problem with high blood pressure is many faceted. So, whenever you overwork any muscle, it's going to go through hypertrophy. When there is muscle hypertrophy, then if it's skeletal muscle and you're doing that on purpose with your biceps, you might look pretty swole, and that's awesome. You have gains, but you don't want gains in cardiac muscle. So we want to reduce the workload on the heart so that the heart doesn't eventually fail. So, yeah, sorry, it's just gonna go like that. So where we are right now is the treatment with hypertension. It's the silent killer. You cannot look at somebody and tell they have high blood pressure most of the time. We want to reduce that blood pressure and also the resistance of the vessels, which means we want to make them more compliant. So we want to decrease resistance and increase compliance. And when you're complying with somebody, it means that you're following their directions. That's different than being resistant, like resisting arrest. That doesn't mean that you're going along, easily. So that's where we are right now, is just talking about hypertension. So to get some background, very quickly again, the heart is, you all have one, even me, believe it or not. Some days I don't. So here we have the heart, and the heart is innervated by both the parasympathetic and sympathetic systems, and they take turns depending on what's going on in the body. So when people are in rest and digest, you're just chilling, you're not exercising, you're not under physiologic stress, there are two nuclei up in the brain area, the medulla oblongata. Sometimes people say medulla. You can say it however you would like, as long as you say it with confidence. So there's the nucleus ambiguus, what a great name, right? And then the dorsal motor nucleus of the vagus that send out projections as the vagus nerve. So the vagus nerve mainly innervates the nodes of the heart. So we have the sinoatrial node, and then we have the AV node. So when the vagus spits out eventually acetylcholine. So remember, the preganglionic neuron releases acetylcholine, and that binds to, I'll draw it down here. So here's our preganglionic neuron and the PNS that is going to release acetylcholine, and that acetylcholine will bind to nicotinic receptors on the postganglionic cell. And remember, nicotinic receptors, those look really nice. This looks like a really messed up, this is like a dead turtle with a long tail. I apologize. So the acetylcholine binds to nicotinic receptors. Here it really looks like a turtle, but he's flying. I have to get out more. There's no other way around it. So the acetylcholine binds to nicotinic receptors that are always excitatory. The action potential is going to spread down the cell. And then in response to that, there will be the release of acetylcholine again from the postganglionic neuron, and that acetylcholine binds to muscarinic type receptors. Muscarinic are always in the tissues. So the predominant receptor subtype that's on the nodes is muscarinic type 2. If you remember what I've said probably 7,000 times if you've taken my classes, if it's an even number receptor, we know that that is going to inhibit the action of that cell. And with muscle tissue, that means its action is contraction. With the nodes, we are going to essentially squirt acetylcholine onto these muscarinic type 2 receptors, and that's going to lower the heart rate. Lower the heart rate, and then reflexively, that's going to lower the strength of contraction. So that would be if you're just, hanging, just doing your thing, not doing anything. But then if you decided to get up and do some burpees, which why would you? But people do that apparently. So from about T1 to T5, we have sympathetic nerves coming out. So just like the other system, the preganglionic neuron releases acetylcholine, binds to nicotinic receptors on the postganglionic neuron's surface, and then that becomes activated, and where we differ now is the release of norepinephrine rather than acetylcholine. And norepinephrine, in this picture it looks like there's one single nerve going to the myocardium, but in reality it's a really complicated plexus in the mediastinum. So if you've ever somebody shocked you, or not like with electricity, but I guess that could have happened. I mean, like startled you. It feels like your heart's going to beat out of your chest. You have this immediate change. And that's because of this really complicated plexus that innervates all of the myocardium, not just the nodes, all of the myocardium, and norepinephrine binds to those receptors. That receptor subtype is predominantly beta 1. Again, if it's an odd number receptor, that means that it's an excitatory receptor. That means it's going to enhance the action of that cell. So let's say you were just doing burpees, you did 10 burpees. You can do that right now. I'm your life coach. Do some burpees. Did you need an excuse? Hooray. So I'll wait here while you do 10 burpees. Okay. Okay, are you done? So when you were doing those burpees, you had a huge amount of norepinephrine being released, stimulating the myocardium to beat stronger, to increase its strength of contraction. Now you can sit down, and when you sit down, the sympathetic nervous system is going to turn off because it's done, and we need to enter rest again. So that would be the case where the parasympathetic becomes activated, and the acetylcholine will bind to muscarinic type 2 receptors to bring your heart rate back to normal. So maybe like 60 beats a minute, right? That's cool. In exercise, you can get up really high, like maybe you're at 120 during those burpees. And that's because of norepinephrine binding to beta 1 receptors and increasing the heart rate and strength of contraction. When we get back to parasympathetic, the muscarinic type 2, they decrease contraction strength and decrease the heart rate by resetting the heart rate. Makes sense? So also in this area, just for your own knowledge, those nodes where we have acetylcholine binding and muscarinic receptors, there's also one other thing there, and it is a really high level of a protein called acetylcholinesterase, which binds to acetylcholine and breaks it down into its component pieces. You can imagine that you don't want acetylcholine binding and staying to these places on the nodes to interrupt the heart rate for a long time. So it's broken down almost immediately. So again, predominant receptors on the heart. So we can target these by giving drugs that either enhance muscarinic action or decrease beta activity. Okay. The other thing that we're targeting in hypertension is the compliance of the vessels themselves. So when we look, I like that green, let's stick with that. So when we look at the type of receptors that are in smooth muscle of vessels, so all vessels have an endothelial layer. It's a thin skin type layer with skin cells. Then there is a muscle layer in the middle, muscle, and then there's a protective layer on the outside called an adventitia. No, this is taking too long. Adventitia. That means that it's a strong scar tissue type lining. Okay, so arteries have tons and tons of muscle, and when you're looking at the receptors embedded in them, there are a couple that are there. There are beta 2 receptors, just free receptors. So they're not attached to any nerve, but they can be stimulated by something binding to them, like epinephrine or norepinephrine. So those are inhibitory type receptors. There's also innervated, so an actual sympathetic nerve here releasing norepinephrine that would signal to alpha 1 receptors. So 2 types of sympathetic receptors. We've got alpha 1, that's an odd number, so that's an excitatory receptor. That means it's going to turn up contraction. When you look at cold medications like pseudoephedrine, I'm trying to write contract. There we go. Those increase the tension and the contraction of these muscles so that the velocity of blood flow goes up. So we're limiting the lumen size, so there's less blood going through and it's going faster. And that helps prevent congestion, which is when fluid leaves the tissue and then makes you all stuffy and gross. So the beta 2 receptors, they're inhibitory. They can be activated by norepinephrine to vasodilate these vessels by telling the muscle to chill. Alpha 1 receptors, they're excitatory, they're vasoconstricting, and whenever you tighten up a muscle, especially in a sphincter like setting like this, now we have less space for the blood to exist, so the pressure is going to be really high. It's similar to this, called the skinny jeans theory of blood pressure. There's only so much room for the blood. Just like if you bought some leather skinny pants, there's only going to be enough room for your body in there. So if you had a huge amount of like delicious Paula's donuts, and that's the only thing you ate for 2 weeks, you might have increased pressure in your skinny jeans. So it's really just that there is a high force against the lining. Okay, vascular smooth muscle, there's not a ton of innervation there. So usually when you lower the heart rate, reflexively, the blood pressure is going to go down because every time the heart beats, you've got about 3 tablespoons of blood, which is like 15 milliliters every time the heart beats going out into the circulation. So if you're exercising, you've got that much blood going out, the pressure is going to be really high. But now when you get back into parasympathetic, the heart rate decreases. So then there's less times that you're adding blood to the circulation. So reflexively, the blood pressure will go down because there's less blood entering the circulation. There are non-innervated muscarinic type 3 receptors, which means they're not attached to a nerve, but they do exist. So here's a muscarinic type 3 receptor, and muscarinic type 3, it's an odd number, so that means it's excitatory. It's going to turn on whatever the action is of that cell. In this case, endothelial cells, they want to protect themselves against what we call shear stress. Shear stress. The force of blood rushing through a vessel is called the shear. Why did they call it the shear? Who knows? Like shearing a sheep. The faster things go, the more likely it is that you're going to scrape part of this endothelial wall off, and then the vessel becomes damaged. So whenever shear stress increases, which means blood flow increases to an area, there is activation of endothelial cells to turn on and start a cascade so that they can help protect themselves. Acetylcholine binding to those muscarinic type receptors enhances that response. What further enhances that is bradykinin, which is a substance formed during the kinin cascade. It's a plasma-derived mediator, which means we have all the pieces for bradykinin out in our blood, but it's only assembled in the case that there's tissue injury. If you've ever been stung by a bee, the reason they call it a bee sting, because it hurts, what they're injecting into you, those crappy little bees, is high amounts of bradykinin underneath your skin. So whenever bradykinin's around, it stimulates pain receptors, Ouch, we don't like them. That's called fast pain, and bradykinin continues to be produced after that initial pain response to keep you hurting, which is adaptive. It helps keep you away from the thing that hurt you. So, shear stress, bradykinin, acetylcholine binding to muscarinic type 3 receptors, again, they turn on this endothelial cell. They allow these channels to open so that we have an influx of calcium, which is a positive ion, which means that cell's charge is going to go up. In this case, this creates a intracellular signaling cascade that begins with a substance called L-arginine, which is modified into something called eNOS, and then eventually into nitric oxide. Nitric oxide is a gas, and it diffuses really well. So we were here, so here's a muscarinic type 3 receptor on the endothelial wall. Acetylcholine would bind, excite this, so that we get the turning on of this nitric oxide creation mechanism. So nitric oxide, it catalyzes a reaction of GTP modified into cyclic GMP, allowing smooth muscle cells to relax and vessels to dilate. So again, this isn't something that's connected to a nerve. Your brain isn't telling your blood vessels, like, lower the blood pressure, please. Loosen up. What's happening is acetylcholine binds and starts this nitric oxide cascade. So vessels do that to protect themselves. So that can be modified and taken advantage of, knowing that we have muscarinic type 3 receptors in endothelial tissues. All right, so in vessels, we have innervated alpha-1. We've got just B2 receptors chilling, non-innervated, and M3 receptors chilling, non-innervated as well. So both of those things are going to lead to vasodilation when they are triggered. Don't get confused. Beta-2, it's an inhibitory receptor, so it tells the muscle not to contract. Muscarinic type 3 is excitatory because it turns on this cascade so that we make nitric oxide. So the end result is going to be nitric oxide production and vasodilation. All right, so that's the physiology. Magic, right? Here is a beautiful table, if I may say so myself, as the person who made it. I am very proud of myself, and nobody gives me the credit I deserve, except for me right now. So the therapeutic objective for these different receptors is outlined here. So let's say you want to vasoconstrict somebody. Maybe they're bleeding too much during a surgery. Maybe there's too much vasodilation because of an allergic response. They took nitro and Viagra at the same time. We're going to want to vasoconstrict. This is what you see in most cold medications. There's different agonists for alpha-1 receptors, methamphetamine, phenylephrine you've probably seen before, pseudoephedrine, midodrine, those are all agonists for alpha-1. Antagonists include things like doxazocin. See that zocin there? That's a drug term. That's important. You'll see zocins and you should think alpha. Ergot alkaloids. Ergot is a substance from mushrooms. So remember we were talking about muscarinic drugs? Yeah, ergot and ergoloid things, they are derived from mushrooms that grow in the forest. Phenoxybenzamine, prazosin. See again the zocin. So we can either turn on alpha-1 to contract, or we can turn off alpha-1 so we dilate. If we want to lower the blood pressure, we can target alpha-2 receptors. If it's an even number, it's inhibitory, so we can dilate blood vessels. One of the most common alpha drugs, alpha-2, is clonidine, not Klonopin with a K. That's a different medication. Clonidin's an alpha-2 agonist used to lower blood pressure. So is guanabens. Those can be used for both hypertension and for anxiety. Speaking of anxiety, we have our beta receptors. So beta receptors, if we want to stimulate the heart, so let's say somebody's dying. They're going through cardiac decompensation. Beta 1 receptor agonists can be used, like dopamine. Remember, dopamine is part of the catecholamine family, and it'll be modified by tyrosine hydroxylase into epi and norepi. So dopamine's a great drug to hit people with. Dobutamine, those stimulate cardiac contraction in the case of cardiac decompensation. So somebody is having a cardiac episode. More commonly, we have antagonist drugs, the OLALs, beta blockers, which are going to block beta receptors and block cardiac stimulation. Finally, we've got our beta 2. Therapeutically, those are used mainly to dilate the bronchioles because we want the smooth muscle to relax. So we're going to target those inhibitory receptors there. The agonist for those drug-wise is albuterol. The endogenous agonist, which means made inside of your body, is norepinephrine, which is why you can give norepinephrine to reverse a bronchospasm.